Hi, it's Dr. Buford. We're just getting started on the left shoulder. We're looking at from the back to the front. Everything that you see is magnified 30 or 40 times on the screen. And I'll tell you what, when I did your examination under anesthesia, you had a bit of a frozen shoulder, which we suspected in the office, but we sure confirmed it once you were under anesthesia. And as we look inside the shoulder, that diagnosis is proving accurate. We can see the biceps tendon here on the right side of that gray cannula. Everything's magnified about 30 or 40 times, so the opening in that gray cannula is only about 5 millimeters. The good thing here is the biceps tendon looks good as I tug on it, and look at the anchor here. A little bit of fraying, but that's normal. That is not a slap lesion. We're not going to have to do a biceps tenodesis. And the news gets even better when we look at the rotator cuff. Here's the articular side of the rotator cuff, and it looks great. It's inserting onto the humeral head right where it's supposed to. And I don't see any need, at least from this articular view, to do anything to the rotator cuff. The most remarkable thing is the redness. So you can see all these areas that are red. You can see how when we do the manipulation, the inferior capsule often tears. That's normal. That's part of what we expect to happen so that we can get your motion back. And you can see the posterior capsule, see how red and angry that looks. That's what a frozen shoulder looks like on the inside. So the main diagnosis here is going to be adhesive capsulitis. You can see redness all over the soft tissues on the inside of the joint. We've already done the treatment for it, which is the manipulation at this point. I don't think we need to do a capsular release because we got full motion with the manipulation, and you can see how even with just the manipulation, things are freed up and the inferior capsule even tears a little bit. So we're just going to flush this area out a bit. We're going to see if there's any loose bodies, particularly down in this region. We'll go off in the video, show you some more in a minute. Grasper. Okay, so the final thing we're doing inside the joint is just having a look from the front to the back. We'll put our shaver in the back. And I just want to make sure there's no, hold the shaver here, please. Just want to make sure there's no loose bodies in the subscap recess. I think we've already gotten the one that we identified on the scan. There's nothing else hanging out down here. You can go on both sides of the middle glenohumeral ligament. That looks good. Here's the joint. And again, you can see how when we do the release, it tears the capsule just as if we were to use a pair of scissors. So we're going to finish up here and get you back to the recovery room, but first we're going to look in the subacromial space. Okay, so we're in the subacromial space. We're just confirming that the rotator cuff looks good on this side. We've taken off some bone from the acromion, as you see here, so now this bone is relatively flat. Maybe a little bit more work we can do, but the bottom line is there's plenty of room between the bone at the top of the screen and the rotator cuff down below. So as we look here at the anterior portion of the rotator cuff, up in this portion of the shoulder, I'm going to externally rotate. That's maximal external rotation. That looks great. We'll come back into internal rotation, which will show us the more posterior aspect of the cuff. And especially as we look back here and rotate the camera around, right about here, we can see that the posterior cuff actually looks good also. So we're going to finish up on the arthroscopic portion of this day for you. We're done with the shoulder. We're going to move on to the elbow. So good luck to you now. I really hope this does the trick for you. Bye-bye.